Now I request Dr. Jagdish Goud. He is currently a senior most surgical oncologist practicing in Hyderabad, and he is well known for a robotic work across the India as well as Asia Pacific. He is a faculty in Da Vinci also.
Good afternoon, chairpersons. Good afternoon to sir. He's a master of laparoscopy surgery and who has designed and designed so many surgeries, especially the prone hysterectomy. I really commend. Is a commendable job he has done to India. And whenever I go to Hong Kong or US, the first question they ask is, how is Palani? So that's the name he has got. I really appreciate him. And going over from there, I feel both have their own role, laparoscopy as well as robotic. And one need to learn, unlearn and relearn so many things in their life. And robotic is in evolution. There are many things that are going to come. A 2 centimeter port and single port is going to come. And the second generation of single port is already there in USA. Only thing, most of the time, we love the surgery, but we hate the company because the company has monopolized the market, and definitely in 10 years, a lot of changes will come. And unless we are ready with the technology, which in our own practice, it's around 30% of our practice. Most of the time, 70% is laparoscopy, but 30% is robotic surgery. So unless we learn these technology, we won't be ready for the future. And this is 2019, we published a data of our robotic hysterectomy compared to thoracoscopy. I still do thoracoscopy, but for esophagus, I don't do. And we have found the lymph nodal clearance and the morbidity is lesser with the robotic procedure in this paper. And there are a lot of trials. I think all of you are learned. I will rush through that. There's some trials, but there's no randomized controlled trial. But many trials have shown robotic surgery is not inferior to the laparoscopy or minimally invasive procedure. At least survival data and the post-operative morbidity and mortality is almost same. Some retrospective trials have shown a benefit in robotic, but it's not statistically significant. These are the different trials that are available online. I think lack of time, I won't go through all these details, but definitely it has been found oncologically effective. My personal opinion for robotic hysterectomy, I still prefer for hysterectomy, I still prefer the robotic approach, especially the upper mediastinal lymph nodes, which are quite easy to do. And especially the left recurrent laryngeal, as Palnivel sir has told, the left recurrent laryngeal nerve node and the aortopulmonary window, these nodes are very quite useful. And presently, with the advent of the robotic sure form staplers and ICG inculcated into the robot, it has made our job quite easy. Of course, expense is the problem, and that's the reason we should all join together and design a made in India robo for India as well as for the world. I think that's where the intellectuals like you all can help in designing a robo which should be affordable and which should be available for everyone, even including the rural surgeon. That's where the real benefit will come for the robo. These are the different advantages. I found it quite good for the upper mediastinal nodes, especially in the esophectomy. And these are the I think I'll rush through these. Regarding the gastrectomy, I don't feel robot is definitely far better than laparoscopy. Both are equivalent, they are doable. But for esophectomy, I feel robo is superior to the laparoscopy. And then for the very low dissections, we do nice and nose now. The intracorporeal anastomosis with the ease of suturing for intersphincteric dissections and direct anastomosis, I'll show 1 or 2 videos. I found it quite useful. These are the different studies of advantages. I think I'll rush through this. But most important is the team. And I'll just show some videos. One of the procedures which we started is a transcendental TME. Of course, the present data, some of the data has shown there is a spillage because of the excess pressures. Definitely it has indications. I personally feel very low rectal cancers, especially post-RT or post-surgery recurrences. This is quite useful. And we do it in our center with an applied gel port which costs around 45 to 50,000 rupees. And we mark the to prevent the gas leak, we mark it below and then do the procedure. And the different, I'll just show you, and this is one advantage of robotic sure form stapler. This is a total gastrectomy for Ivor-Lewis adenocarcinoma of the, especially nowadays we see a lot of adenocarcinoma of the esophagus. It has made our job easy. So this is a sure form stapler which has a automatic compression sensitivity. It doesn't fire if it is too thick, and the ease of access, the end of wrist. I have seen most of the time we struggle during total gastrectomy. Everybody is not as perfect as Palnivelu sir. So you need an assistant who is going to do the firing. Whereas the robotic stapler, this is Ivor-Lewis, which is more common, and we just mobilize the lower part of the esophagus, do a side-to-side anastomosis with the sure form stapler. There are 60 as well as 45 available. I usually use 45, but for total gastrectomy, I use a 60. And then we do the anastomosis and fire below the growth, below the anastomosis there. That removes the total stomach. This is the sure form stapler. And do the suturing of the angle. That's how we clear. And that's the anastomosis. And this stapler is available as black, gold, green, white for especially lung cancer, where we use a pulmonary vessels, pulmonary artery, and so many cases. This is very, very useful. The surgeon controls the stapler, and it has a sensitivity where it doesn't fire if it is too thick, and we can change the stapler in the console itself. We can change and we can code the color. These are the different advances. Robotic surgery is not just cutting and chopping. It has some other things along with that, and that's how we do that. And the rest of the part, we do the anastomosis, including the total. And then if you go for recurrent laryngeal nerve lymph nodes. And there's one more procedure which I do for piriform fossa, small radiation recurrences, transoral surgery. It's a beautiful procedure without opening your neck, and morbidity is very, very low in these cases. We just go inside in the piriform fossa, put a port, 5 mm. Now the instruments are available of 5 mm and as well as 8 mm. These look magnified. This is a small lesion. Earlier I used to do a lateral pharyngotomy, go inside and do the resection. Now I just do a transoral robotic surgery, put the port inside. Because of the end of wrist and magnification, it looks beautiful, and we can always send for frozen section for the margin. And there is no need to do any, because we do neck dissection beforehand, and we ligate the vessels and all, so bleeding is quite minimal. There's a way to do it. So these are transoral, transanal, and esophaectomy. These are the cases which is found quite useful. And CA rectum with ICG inculcated in that, we use a nice and nose procedures quite easily. Of course, laparoscopy also has a role, and then we can use a stapler to fire it. That's how we do a nose. We put the anvil inside. Very low rectal cancer cases. These are the cases where we cut. We don't have to put a stapler. We just cut it and do a hand-sewn with the robotic hand-sewn anastomosis. The anvil is brought inside, and the anvil is pushed inside, and that's how you go inside. And you don't have to close that rent. Bring the tip through an incision, and then fire a robotic stapler below that. See, that's how you do that. So these are the advances that are coming in robot. And unless we start doing the basic things, we can't be perfect in all these things, all these different approaches which are available. And below that, we use a stapler, simple 45 stapler with angle. One should use a robotic stapler in lung. It's so beautiful. The pulmonary artery, pulmonary vein, bronchus, you don't have to struggle. And a perfect surgeon needing a perfect assistant is difficult sometimes, except few centers like GEM Hospital. So here the surgeon himself is responsible, and then we take it out through that. The whole procedure is completed robotically. There's no need of giving a phalansteal incision. Of course, I know Palnivelu sir has done laparoscopic nose long ago, and that's a stapler. You can just fire it and then do a end-to-end anastomosis. So these are the different advantages. You can see the stapler, such a beautiful end of wrist it has. And it is worth doing it in LARs, total gastrectomy, and lung cases. So this is a sure form stapler. This is 8 mm. Now 5 mm has also come. 12 mm, 8 mm are available. Of course, India it's not yet launched. It is launched in US. So there will be more. The Da Vinci company is just waiting for other companies to pick up. Once the competition hots up, the Da Vinci is going to introduce a lot more. And the specimen is extracted through the anal canal. I feel this is a challenge most of the time, but post chemo RT cases, we extract it, but post the primary cases, I take a small specimen extraction bag, put it through the ring, and then take out the specimen. And then the specimen is pulled out there, and the anastomosis can be done hands even. There's no need of stapler. Directly we can do. I'll just close this. So these are the different things. And stomach cancer, esophagus, I'll just show esophagus. And then I'll close the. This is not seen, 1 second. So this is the biggest advantage of, I personally feel, is recurrent laryngeal nerve lymph nodes. That's how we do port. Of course, Palnivelu sir was a pioneer who started the prone position, and we use prone or semi-prone. Only 2 instruments are used, is monopolar and bipolar. And you can because of the endowrist, no tremors, and steady instruments, and 5mm and 8mm instruments, so easy to do visualize anatomy. This is 2D, but when you sit on the console, it's 3D, and this is an immersive 3D. Unlike the laparoscopy 3D, which I have done, the assistant sometimes keeps moving the camera, and it gives a headache to me. Whereas the 3D in Da Vinci is the most stable, most immersive 3D, and it looks natural. The colors are natural. You can see over the bronchus. You can just go on to the left side and remove the lymph nodes on the recurrent laryngeal nerve as well as the outer pulmonary windows. And we don't use an endotracheal tube, double lumen endotracheal tube with the pressure at 8 millimeters. And it's a robotic clip applicator, especially inside thorax, where you need to do complex procedures. Definitely the robotic approach is quite useful. And I personally feel this should be in the armamentarium of every surgeon. God knows what more innovations are going to come in the future. You can see the recurrent laryngeal nerve on the left side is different. The axis is straight, and the right side, it turns over the subclavian vessels. And the anatomy is quite different in the prone and prone position. So we do dorsal and ventral side of the recurrent laryngeal nerve and do the dissection, and always remove them through a bag. We never remove them through the port to maintain the oncological clearance. This is like even the assistant is not needed in these cases. Though if a perfect surgeon wants to do a perfect surgery, this is the way to go around. And I think I'll just rush through that. We can see that's a posterior membranous trachea. You can just bend the scissor and go on to the other side. This is where I personally feel advantage in doing these robotic procedures. And we'll go on to the recurrent laryngeal nerve. I just show the RLN. See, that's a vagus nerve. Once we remove the bronchial nodes, we go on to the RLN, the right RLN and the left RLN. Because of 5 to 10 times, this is 5 to 10 times the magnification and minimal cautery and steady instruments, it's easier to do. Only thing, if the company we are still fighting with the company to make it affordable, and we have joined with an IIT and ISB and some intellectuals trying to design a made in India robo, which should be useful for the humanity. I personally feel there should be more competition, and which will benefit people. The cost will come down, and the humanity overall will benefit. And surgeon, if he is able to sit on a console and do the same surgery as laparoscopy comfortably, coolly, and clear the nodes, clear the vessels, control the bleeding with a cool head, and easily, naturally, the results are going to be there. But to get a randomized control trial and get a benefit, it's going to take long time. For example, when I wanted to do laparoscopy, I heard Palnivelu sir, but there was a clash in our institute, like oncologically, it causes port site metastasis and all. So we were slow to start laparoscopy. Whereas in the robo, we didn't do that mistake. We started off early, 11 years back, and to get the randomized control trial data, it takes another 15 years. By the time we would have become old and we would have lost the edge. So personally, I feel there's a room for everyone. There's a room for everyone, and one needs to balance. Initially, when I started, we used to do 4 cases a day because the robotic company used to charge us 1 lakh per day. So what we used to do from 10 o'clock to night 12 o'clock, we used to do the cases. Then company realized this guy is utilizing our rules. So they started making for every case charge separately. So over a period of time, we learned how to adapt, how to evolve, how to control these things. And definitely a lot of changes are going to come in the future. And this is the first robo which we started. I had a fortunate opportunity to work with all 4 generations of Da Vinci. I feel there is no other robotic company that can beat Da Vinci. I have gone to Sharjah for CMR. I have seen the Medtronics. Medtronics people are still not yet sure what to do, what about it. So, but I had a lot of hope from Medtronics. And hopefully they come out with a good reason and good package so that the cost comes down. Unfortunately, the cost is same as the Da Vinci. I still feel J&J and Medtronic should come out, and then the cost of the robo will come down. And this is the X generation, and this is the robo I had training 3 years back in Yonsei University. Yonsei is the mother of all robotic surgery for us. So this is a single port, 3 centimeters. All these big instruments are inside this port. So again, after this, another generation also has come, and that's the way the progress comes. Unless we start with the basics and go on with all the other things, it won't come. I feel artificial intelligence, virtual reality, and augmented reality. Already, ICG is nothing but a form of biological augmented reality, where we see the thoracic duct, we see the lymph nodes, we see the perfusion, where to cut, where to make anastomosis safe. So I feel this augmented reality will be useful for teaching. For example, Palnivelu sir can sit in GEM hospital and can teach where to cut, where not to cut. So that's going to be a big change in future. And robots have become very flexible to do all this. There's Boston University is doing a lot of work. And in the future, medical oncologists may be doing our work, injecting nanobots into the blood cells. We don't know whether I'll be there for those. And also, sensors are being inserted into the chips of the skull and to control the instruments. This is in infancy, it has not yet developed, and maybe in future robot will be delivered to the patient's house. That's how the change can come. Thank you so much, ISGO, for giving me this opportunity, and thanks to Rajni sir who called me whether I'll be ready for this, and thank you, Chairman.
Thank you. Excellent talk, both of you. As I know, because since last 15 years I'm observing Professor Palnivelu sir and Dr. Jagdishwar Goud. Both are well versed in laparoscopy as well as robotic. To say a message to the audience or our national younger generation, scientific way up, because you are both experienced in both systems. So what is the advantage of robot? What is the advantage of laparoscopy? As you know, minimally invasive, less pain, early recovery, these are all everybody knows. But what exactly advantage? Personally, I have observed in a laparoscopic donor hepatectomy, I have observed my example, I will tell you. Parenchymal transection, when you start robotic, we have dissected Patta, everything nice, good illumination, 20 times magnification, very closely watching the anomalies, everything perfectly dissected. When it is come for parenchymal transection, we need a CUSA, we went for a laparoscopy. Then again, when we are reaching the cava and right hepatic vein, reaching in a flexible manner, laparoscopy is limited, then we switch the robo. So like that, so many examples, robotic, nerve sparing, radical prostatectomy. So that is a more advantage. In GI surgery, with your both experience, which one scores better? Like recurrent laryngeal left side in minimal esophagectomy, it's better. So can you tell your experience, then it will send a good message.
Sir will tell, he's a senior.
Yeah.
But in other words, I'll simplify the whole thing. There are a lot of youngsters here. Should they learn robotic surgery? If they have to learn, should they learn right away, or should they wait for it to evolve a little more and then learn? Sir, Palnivelu, sir.
Robotic surgery should be learned. It should be part of the syllabus in all institutes. when I go every year to Severance Robotic Institute, when I see the young chaps of 25 years, 30 years doing robotic surgery like that, I feel I have become old. And many times I feel I don't have time, so many years to do these things. So it's an evolving field, and the sooner you get attached to it, you should do it. But the judgment should be there. For example, when I started, I used to do cholecystectomy, everything, because I was learning 11 years back. Now I have designed myself, I have restricted myself, I speak to the patient, I give them the options, I don't force them, but I'll tell them lung, esophagus, transoral surgery, transoral robotic surgery for recurrent or post-RT recurrences, very low rectal cancers. I tell them robot has advantages. Stomach, I never force. Stomach, right hemicolectomy, I never force. Whipples, I never force. I give the choice to them. But these cases, somehow I feel personally my own experience advantage. But one should never refuse this technology because it's expensive. It should be part and part of the curriculum. You just go to Korea and see Severance, you'll feel so old. You feel you have lost the edge. So unless the youngsters learn it, and they should, with seniors like Palnivelu sir, and so many of you people like Madhu and all, you can design a way which case should be done, which case should not be done. So that judgment will come over a period of time.
But Palnivelu to respond, yeah.
Yeah, congratulations Jagdish. I've been seeing you from the beginning and started doing a basic surgery, laparoscopy, then went to robotic. That's why I could see your robotic surgery is so excellent. All robotic surgeons are not doing the same quality. And like Jagdish and a few surgeons who are master laparoscope, they are able, when they change to robotic, they are good quality. Directly to go robotic, they have a lot of limitations there. For example, if it is a cancer, and diagnostic laparoscope exploration more important before docking to robotic. Suppose you are connected by the time there is a peritoneal secondaries, which is not imaging picking up, then the unnecessarily it become a waste of. So that's why for the beginners, those young surgeons, you can't ignore technology. As Jagdish put in, we have to learn. Technology sense, we have to learn all the way, laparoscopy, robotic, and we should know where to use, how to use, and safely, and also looking at the patient's capability. Just like a robo is better, all cancers advertise, oh, it should be done robotic, then that India today cannot face this. So as Jagdish, I also with him saying esophagus and low rectal cancer, and narrow pelvis particularly, or if it is whipples where a bile duct or a pancreatic duct, soft pancreas, I'll recommend robotic to go. To go to robotic, we need a minimally invasive surgery experience to go. Learn both laparoscope, robotic, and that is very, very important. And generally jumping to high tech, then it is. And Radhakrishnan or Madhu or Jagdish, we are all open surgeons, become laparoscopic surgeons, and now becoming a robotic surgery. I enjoy robotic doing it, but today current scenario, it is available in limited centers. Only few surgeons are capable of doing cancer. So that means we have to take care entire country today. As I join with Jagdish and all of you, and we will make a forum for technology development. We make in India. We should have our own robo system, not depend on any companies. Why should work for a company earning everything giving to them? I think we will be working out that angle and learn everything and choose the procedure where to do, how to do, make it this separate. And general surgery particularly, 80% of basic surgeries are other than cancer, and their laparoscopy is the standard of care. Everybody has to learn gallbladder, appendix, and fundoplication, smaller surgeries, laparoscopy. That experience will give you more towards. That's why when I started robotic, unlearning everybody felt very bad, difficult, no? Within 6 months, I could do whipple, I could do esophagus, and that procedure where it is standard. Because learning is step-by-step learning. I think today I joined with Jagdish, give a simple message, and technology is very important. You have to learn robo. You cannot ignore artificial intelligence and future augmented reality is going to come. Contact probe, intelligent knife, all is coming in way, but still not available right now. But in soon it will be there. We have to catch up that for that open mind learning mode. That is better.
Thank you, sir. Purnendu, what is your take on robotic surgery? Would you advise?
I think a new technology, initial that hesitation will be there, always. There was a time when people were worried that once everywhere people started doing laparoscopy, whether the juniors and the first year students will be skillful in doing open surgery at all. Now my worry is, maybe I won't be there 40, 50 years later when everything is being done robotically. Now even plain laparoscopy will get outdated. And I'm concerned and thinking, who will be practicing normal surgery? So in case if there is a problem, that's the only thing. But if you have access, why should we not? I mean, it's like people who use normal car, he says, I get pleasure out of changing the gear. I love to press the clutch and then change the gear. I get a feel that I'm driving. But anybody who has driven an automatic car will never want to go back. So maybe a time will come, we all will have access to robots. And then the question comes, why do we need to do open surgery? Means everybody will be able to be an expert in that. So yes, it's a thing, we must accept it. All of us who have got access should practice it. People should, along with the legends, should take the juniors to go ahead and let's continue. But I only feel is, I remember about 20, 30 years back, I insisted that I want to show all my complications. And that was the first time when I introduced to have a session called Disasters in Surgery. And I get a feel many times, like even when we talk about POEM, endoscopic for achalasia, we need to talk about that we are not able to handle the reflux, we are just cutting the muscles, then what happens to the reflux? We need to also document how many perforations took place. So somehow I don't see the complication.
I think that's a good suggestion, that the initial surgical complication need to be discussed. Govind, what is your take? Why did you take up robotics so seriously? Do you advocate to the younger generation? When should they take it? Right away after they finish their DNB or MCH?
I think definitely robotics is in, but gradually for all, some specific areas definitely robot definitely has advantages. And I think we should give it to the patients, and cost definitely over a period is likely to come down. So that technically people should be at least aware and they should know all these things. And one of the ways I feel is also they should start doing some hybrid procedures also. Initially, if they are good in laparoscopy, like we had an older model of SI robot. At that time, we started doing laparoscopic splenic flexure mobilization, and then for the pelvis, we docked the robot. Similarly, for a total colectomy, you do one side laparoscopically, and then for the pelvis, where it is much more useful, you dock the robot. So those are the things you can gradually push your boundaries and then get ahead with it.
Regarding complications, we do have videos, sir. I think no surgeon can claim that he is complication free. Like I have a robotic ischectomy where the conduction current from the elbow caused a bronchial membrane tear, but we sutured it. Then one more case, we had IMA tear. This is just a start, I think. You should have a full session in one 2 hour session of robot in ISU. Then we would like to present it.
Rajneesh, you'll have a last word from you before we close. We are out of time now.
I'm not the person to give a last word, so these are giants in the field. Okay. My only one small query to you, and I think sir has already answered that query, I'll still put it out. And I think it's a myth that an open surgeon graduates to robotic surgery easier than a laparoscopic surgeon graduates to robotic surgery. To my mind, that's a myth perpetuated by the companies, because there are far too many open surgeons who will buy robots than laparoscopic surgeons who will buy robots. But I have graduated from a laparoscopic surgeon to a robotic surgeon. I won't say robotic surgeon, a bit of robotic surgery. I found it very useful because the angular view, the principles of surgery are similar to laparoscopic surgery than to open surgery. Maybe a point of view would be appreciated.
Yeah, I agree with you, sir. I think all are required.
Any other comment from the audience?
Just one word. And robotic surgery, Chinese, they call it robotic assisted surgery. And they don't call robot. It's not a, postgraduate should not feel it is like humanoid type. Robot is coming doing a surgery like. It is a programmed instrument surgeon operating it. So again, skill only depends on the surgeon's skill and how doing it. That's why it is, we need to know both technology and adapt it accordingly we have to go ahead. That is very important.
Sir, Parliament, sir, if somebody asks you to do a hernia robotically, gallbladder robotically, will you do?
If a patient asks me to do it, I will do it. But if you ask to demonstrate in a workshop a hernia to do it, I will not do it in India. I will do it last time, a few years before to America, I did it. Why? No, American needs robotic. For them, money is different. India, I cannot show robotic hernia done. And where you going to solve the problem? It's such a common problem. Laparoscopy is the way to do it, any type of hernia. So the procedure depends on. Patient is asking, he has got money, want to do it, fund application. The patient asks, I want a robotic. Fine, I did it. Patient choice has got, we have to, cannot ignore. We have to go with them. But same time, more important is that when they impress the other surgeons, something we should not convey wrong things. They should not go, okay, robo needs to do a gallbladder, to do appendix, to do a, that is highest technology. That kind of field should not come. We need to know what it is. Yes, Madhu?
One quick question, sir.
Yeah,
Any open surgeon wants to become a robotic surgeon, is it need to go through the laparoscopic skills, or you can go directly robotic? With your experience, with your Jagdish sir also.
Yeah.
Open, because many of the open surgeons wants to do robotic. Is it possible, or they have to have a minimum of some laparoscopic skills and to become a robotic?
Yeah.
Can it possible direct?
It is a two type of practice. One is onco practice, the another is a general surgical gastroenterology practice. General gastroenterology practice, like MS general surgeon wanted to learn, they have to learn laparoscopy, not robo. If onco surgeon wanted to primarily, like a Jagdish, he is a cancer surgeon. There are some Indians who are doing excellent cancer surgery today in robotic. Yes, there they can go robotic like a pilot training, and we have to learn the best of the robotic and they can practice. But again, for them, the laparoscopic assistance, very important. One of the surgeons in the team must be trained in laparoscopy and know how to do it. For example, irrigation, retraction, and suppose it bleeds sometimes to help. And it is not that robotic, everything the surgeon can control it. So one of the laparoscopy trained surgeon must be there in the team. It may be even a staff nurse. For example, you all know GEM hospital, staff nurses are 30 years trained, they know how to get it done. So trained people, one of them must be there on the table, and the surgeon cannot put up and come and take it bleeding open. Even for before opening also, something needs assistance. So cancer surgeon learn robotics straight. They are primarily, after some time only minimum robotic surgery is going to be the primary care, I know it. Now esophagus, rectum and delicate structures and prostate. Future, all cancers I will recommend for robotics.
Well, I think we have run out of time. It's a wonderful discussion, but then the message we get is that robotic surgery is going to be the in thing in due course of time, and we all should get to it some point of time. Everybody is open to technology, and since the whole world has adopted it, we should adopt it as well. And thank you, sir. Thank you so much for your time, and thank you, Dr. Goud, for the presentation. Thank you all.